My practice is at UC Davis and Shriners Hospital. I do about 30% pediatric and 70% adult. And today I'm going to cover anterior column support in adult spinal deformity and focusing on ALIF. As we know, and it's been reiterated, sagittal malalignment causes disability. This has been well parsed out in a lot of studies that we've looked at, and we know that the spinal pelvic parameters predict patient disability and also make our decision-making a lot easier in terms of what we need to achieve, and the severity of symptoms get worse as the malalignment is more severe. Also, we know that the reconstructing and hitting our alignment goals will improve the patient health-related quality outcomes and their functional status. So I'll start with a case. This is a 60-year-old patient that had several prior spine surgeries, was at some point extended to T5, and with partial hardware removal, and presents with quite significant sagittal malalignment. The parameters are listed over here, but you can see that the SVA is quite large, and looking a little bit closer at her CT scan, her advanced imaging, we could see that there are some lateral interbodies that were placed in the upper spine, a posterior approach at L4-5, but 5-1 has a peak type cage and fracture and pseudarthrosis. So again, looking at our traditional options on how to approach a patient like that, obviously, the thought process would be potential osteotomy for a correction of larger sagittal deformity. As we've talked about, anterior column support potentially giving us a very, very powerful tool when I call this the window of opportunity with a big pseudarthrosis. And you can see that potentially the problems over here are coming at the lumbosacral junction, at the L5-S1 junction with pseudarthrosis, and that gapping open you can see on the supine CT. So the choice for a hyperlordotic ALIF for anterior column support was considered, and with posterior fixation, avoiding a posterior column, 3-column osteotomy in this patient. And these are the final results. And just to, since we had a very nice talk regarding multiple rod constructs, even in my ALIF constructs, I'm using a short satellite type rod to hold the ALIF in place, and that allows me to not put as much bend in the distal aspect of the primary rod, and also with satellite iliac fixation to dial in the coronal alignment. And a very good paper that was recently, I think this is about to be published, and Steve is one of the authors, showing that in large patients with large sagittal deformity, ALIF can restore the lower lumbar lordosis L4 to S1 as powerfully as a PSO. That the intraoperative complications are definitely less, and that the TLIF might not be as powerful in doing so. If you look at some other literature, you might see that, that ALIF, even though it does restore the lower lumbar lordosis, is similar to TLIF, but if you parse down on the numbers, you'll see that the SVA on the cohorts that were chosen were quite small. probably between 3 to 5 centimeters. So for these very, very large SVA patients, the use of ALIF can be a change where PSO is then not needed. This is another case example where the L5S1 was not fused, thankfully. However, the patient was fused with lateral inner bodies and a long construct, and even thought was given to PJK prevention with the cementing of UIV and UIV plus 1, UIV plus 2, but I think they forgot the rod benders that day, and so they got pretty flat rod in there. So if we look at the pelvis on the AP view, it has the retroverted shape, or sometimes called the champagne flute sign for the trainees in the audience. And the advanced imaging in this particular case shows a very nice, solid posterior column fusion, and even with anterior osteophytes covering the L5S1 disc space. I think the key in this case for me was the little bit of air that could be seen on the CT scan at the L5S1 junction, and initial consideration for a PSO at L3 or L4. However, again, with that window of opportunity, the decision was made to use anterior column support and hyperlordotic ALIF, and with a potential, if we need to go to a PSO. However, that could be avoided as we were able to get good correction. And one of the reasons is because this provides a long lever arm for our correction at the base of the L5S1 junction, and it improves the actual pelvic compensatory mechanism. So the pelvic will regain its posterior tilt better than if the lordosis was in a higher position. So this is a paper looking at the anterior hyperlordotic cages and some early experience, and it showed that the ALIF procedure with large magnitude of a posterior that could avoid a large posterior osteotomy, and that these larger cages did not have increase in complications. However, I think with putting cages that have high anterior height, the one worry for me is causing an L5 paresis or paraxia. Special attention is paid to neuromonitoring when we size these cages. And if we do see a change in that, we have to be cognizant of how much distraction we are putting at that disc space. So what about a fused L5S1 level? Is anterior column support ALIF still an option? I remember this case very well because this is one of my first deformity patients, and I had to present this at my boards to a panel of experts. In this patient, the prior surgery was a L4 to S1 MIS TLIF with peak cages. And after a decision of removing the posterior screws, this is how he presented. So looking at advanced imaging, you could see that through the inner body, there is good fusion at L5S1, even though it's several spot weld fusions. And in the anterior aspect of L4-5, there's a large osteophyte, and those segments are stable. So in making a decision on how to correct the sagittal alignment of this patient, the thought process was, well, if we perform posterior Ponteos mid-P-type osteotomies, is that going to give us enough magnitude of correction? And with a larger deformity, with the SVA approximately 27 and needing to get about 60 degrees of lumbar lordosis, that's probably not going to add up to enough correction. And then the other thought would be a posterior column osteotomy, maybe a grade 4. As you know, the complication of those osteotomies and amount of blood loss are larger, and especially for younger surgeons when they're in their early careers, they might not be as facile of an approach. There are open disc spaces at the mid and upper lumbar, and we saw Bob give a good kind of reference to using ACR, so placement of lumbar interbody fusion with release of the ALL. But we also know that that will potentially put our lordosis in an unnaturally high position. And what about ALIF? And again, the problem over here is that the patient is already fused. This is actually a favorite paper of mine by Steve, where he looked at the high UIV angle of the upper screws, and I think this really simplifies the concept. And I look at this very closely: is where do you put your lordosis really does matter, and PSOs are not perfect. And when lordosis is provided, and traditionally we were doing these PSOs at L3, it's kind of been placed in the mid-lumbar area, you would have that hyperextension of the upper end of the construct when it was at the low thoracolumbar junction. So in this case, again, we decided to do a revision of and osteotomize through the already fused segments, and with a 2-level ALIF, we were able to achieve the lower lumbar lordosis and get a correction in this patient with improvement of their HQRL outcomes, as you can see. So in summary, ALIF can achieve sagittal realignment, and as recently shown, it could be as powerful as a pedicle subtraction osteotomy. Its potential advantages are placing the lordosis in the lower lumbar, and there's a plethora of literature coming out again on that. And the long lever arm for correction is one of the big reasons why this is very advantageous, and it is a powerful tool. And again, we have to talk about the potential disadvantages of the second approach and approach-related morbidity. And in most cases, need for approach surgeons. So I do not do my own ALIF approaches. I know some of you guys might do that. However, that is a disadvantage. So thank you. I'll take questions.
Well, thank you for the great talk. You brought up a really important point, I think. I don't always use neuromonitoring for my ALIFs, but when you're using that hyperlordotic ALIF cage, I think it's less important because you're not really getting as much height in the back. How do you try to balance that correction of maybe foraminal height versus alignment when you're doing these cases?
Yeah, great question. And, I think that's been an evolution for me. So initially, when I started using the hyperlordotic cages, I was cutting my own allograft, and the good thing is you can dial that in, but again, it does add OR time and is rather cumbersome. But I think the important thing that I've come to is that you kind of need a minimum posterior height. And somewhere between 6 to 8 millimeters is kind of the sweet spot. And as these cages get more lordotic, they lose their posterior height. So there are certain companies that have 30-degree cages. I almost never can use these because they have almost a 20 or 22 millimeter anterior height, and the posterior height is too small. So your foraminal height is not going to be restored. So just by experience, I would probably say that most commonly I'm using somewhere between 20 to 25 degree cages. And again, we had an excellent talk on patient-specific implants, so that could be potentially a solution for getting it dialed in. But usually 20 to 25 millimeters, 20 to 25 degrees lordosis, and about 6 to 8 millimeters of posterior height is what I shoot for. And again, I am looking at neuromonitoring. If there is any drop, I try to not have such a large anterior height. In general, not more than 20 or 22 millimeters of anterior height. I feel like that's where I start getting in trouble. Yeah, Fred.
That was a really nice talk, Yashar. Thank you. Quick question for you. When you're looking at getting so much correction, especially in like an iatrogenic deformity from the front, do you have any specific bone quality thresholds that you're looking at, and how are you measuring them preoperatively?
Great question. That's absolutely a very, very important consideration. I think, for example, in a patient that was already fused up to, my second example was already fused up to T10 very solidly. In those patients, I'm a little bit less worried because I know there's sclerotic bone at L5S1, and I'm putting a large bony inner body or maybe titanium inner body at that stage, and I'm fixing it to the pelvis. So I'm actually less worried in a patient like that. And in that patient, we actually just added on to the mid-lumbar. So we used the existing, and I didn't even open the incision all the way to the top. However, in general, when I'm performing revision surgery, patients get DEXA scans, and they also get a CT scan. And I'm always looking at the Hounsfield units at UIV +2, UIV +1, my UIV and below to see what those averages are. And Paul Anderson has a really good paper out on that to look at that. And if the patients are questionable in bone quality and are osteoporotic, our protocol is a bone anabolic agent. Usually most of our patients get Forteo at this point, and about 6 months to 1 year of Forteo before surgery.
So you're sticking with Hounsfield units up at the UIV, UIV +1, and less so down at L4, L5, where you're doing those big ALIFs.
Yes, generally, I'm less worried about that sclerotic portion at the lower part. But again, there are some patients that are very osteoporotic, so not that we're ignoring it, but I'm much more worried about the upper end of the construct than in a revision setting like this.
Yeah, that was a ridiculous correction you got on that guy from the front with the fused disc basis. So, I mean, that was technically very difficult, and you did a really nice job. I think another thing for neurologic monitoring is incomplete discectomy, where a piece of disc is left in the back, and then when you hammer your cage in, you may dislodge that into the canal. So something else to consider for not necessarily the size of your implant, but also kind of a retained disc fragment that may need to be dislodged. And I have seen a case of that where you had to do a posterior and open it up and get the piece out. So, but I think you really showed really nicely how powerful the anterior column. I think the importance of restoring the distal lordosis was also stressed, and those are really two key principles for us to move forward. So thank you very much.
Okay, thank you.
One more question.
Yes.
Can you hear me? So Yashar, wonderful cases, outcomes. They look beautiful as always. I'm a big proponent of anterior operations as well, especially down low at L4 to S1. In terms of preventing the cages from kicking out from the front, because when you go to the back and you've released the ALL, you've done a nice release overall, and you're cantilevering, usually distal to proximal. Some people do it cranial to distal. Those disc bases can even fish mouth and open up more. I've started to use integrated cages and kind of belt and suspenders, put a buttress screw on the front on the same end plate as those screws, because I've had issues with the cages coming out, or at least loose, becoming slightly loose. Have you had experience with that, and what are your ways of preventing that from happening?
Absolutely, and great question. And I've had the same evolution. So we kind of have very similar training. We were both Manisha's fellows, and as you know, initially when I started practice, I would use the allograft, and we would use a screw and a washer. And the great thing about that, it is very cheap. And every ortho set, you can get it from the trauma set. But I have seen in my practice one time, and with my partner's practice several times as well, that the cages dislodge, and these could be immediate, like you flip the patient and they're dislodged, and we've seen it in stage patients and also early before discharge. So a big concern, and one time I've seen the screw actually just kind of plow out rather than the cage pop over, but I've also seen it pop over the washer because it's very small, 2 to 3 millimeters. So the evolution to that was to plate from the front, usually a buttress plate. I've seen that fail one time as well. So just like you, I have gone to interfixated interbodies where there is a large screw, usually with 3 interfixated screws, 1 usually in the sacrum and 2 up to L4, and I have not seen any issues with that. But I will tell you, when I'm doing it interfixated, I don't put a buttress any longer, but I think you might be a little bit more safer than I am then.
That was. Can I ask one question? So, one more thing about these hyperlordotic cages. Aleko's great comments. I still don't know what inverted cages are. You have to explain that to me. But the secret to success is less maybe the implant, which is important, but also the release technique. So, can you just share in 2 or 3 nutshells what are the key things for a successful release of the anterior column, so you have actually a great chance to realign the spine through your carpentry and insertion of the device without imploding into the end plates?
Excellent. Thank you for the question. I think obviously exposure is number 1. So in our institution, we have very good, safe exposure surgeons. They are they take a little bit longer time. However, the patients I usually bring are high BMIs, they have comorbidities, they have prior abdominal surgeries, so I can't fault them in that. They're extremely safe, and they give us very nice exposures. Their exposures are not very small, so they might not be appropriate for ACS type surgery. However, again, these are larger revision cases, so exposure is number 1. But I do a complete release of the anterior annulus, and then very carefully with a cob, I take the disc space and then with curettes and maybe a little bit of a back cutting rasp, it prepared the end plates. I think one of the places that are missed is the lateral aspects, which is right under the vessel. So I usually use a down pushing curette because I'm quite afraid of pulling up towards the vessel and getting a vascular injury. So I use a down pushing curette, and very regularly I will go to both sides of the table and kind of just make sure I've done a thorough discectomy and a release. Couple of the pictures also had, we use a large footed distractor to distract and break those posterior osteophytes. I do not regularly take the PLL. However, I do scrape the PLL with a curette and make sure there are no bony osteophytes, as Steve mentioned, posteriorly, because they can impact into the canal. Thank you for the question.
All right. Well, thank you again.